Hello, everybody, and welcome to today's webinar, Health Begins webinar. We are just about to start. All right, so thank you all for joining today's webinar on investing for the future, new ways for institutions and communities to fund and manage upstream investments. My name is Dr. Rishi Manchanda. I'm President and CEO for Health Begins, and I have the privilege of being joined today by Lisa Richter, Managing Partner and Co-founder at Avivar Capital, and Lauren Taylor, a doctoral candidate in Health Policy and Management at Harvard Business School. Before we start, we would like you to know that this webinar will be recorded, and we will be sending this recording out to all registrants after the webinar. As a reminder, all participant lines are on mute. If you have a question for us, you can enter it at any time in the question box that appears on the GoToWebinar doc. We have reserved time at the end of the webinar to answer questions that come through the question box, so please do use that question box and feel free to use it at any point as questions arise in your mind. The presentation is scheduled to last for 1 hour. Before we dive into the content, I want to review some of the learning objectives for today. And by the end of this webinar, we hope that each of you will be able to describe financial and sustainability challenges facing institutions and communities seeking to improve social determinants of health, and to that end also social needs for individuals. We hope that you're able to emerge from today by being able to at least list 2 ways in which impact investing or the trusted broker concept, as you learn about today, relate to your own work. And lastly, we're hoping that you can list at least 2 new approaches or resources that institutions or multi-sector collaboratives and communities can try to better manage, finance, or sustain social determinant solutions. So that's our hope for today. As a reminder, please do use that question box using the Q&A pane to submit your questions or even comments. We'll answer those questions, as I mentioned, at the end. And please do follow us on Twitter during this conversation and afterwards using these handles here at HealthBegins, at Lauren Taylor MPH, and at Avivar Capital. Not only during the conversation today, but afterwards, so you can continue the conversation with each one of us. And as you do so, just to keep track of the conversation, we're recommending the use of hashtag #InvestUpstream. So with that, it is my pleasure to welcome Lisa Richter and Lauren Taylor to this conversation. You're going to hear from each of them shortly, and they are the main presenters for today. And I think you'll all find that each of them brings a substantial amount of expertise and just keen insights on the question at hand for today, based on their work. For those who are joining who are not familiar with us at HealthBegins, HealthBegins was founded in 2012 and has become full-time over the last 2 years. The bulk of what we do is to really focus in on how to improve both care for individuals as well as social determinants for communities by making clinical and community partnerships more effective. And we do so in a number of ways, and privileged to work with a lot of organizations, including perhaps some of you on the line today across the country. So enough about us. Let's understand who you are. So I'd love to start by launching our first poll for today, just to get a sense of who's on the line. We're seeing at least 105, 106 already on the line here today. So while the poll is open, tell us what best describes your organization or your association. And you can see the answer choices there. We'll leave it open for another about 10 seconds or so. Great. All right, let's go ahead and close the poll now and see who we have on the line. It looks like a really nice spread. About 1/3 of folks are from hospitals or healthcare delivery systems. There's a 33%, exactly 1/3 who are other. So please let us know in the comment box or the Q&A pane how you would classify your organization if not using one of these categories. So please do let us know. We'd love to learn more about your backgrounds. A good 22% are community-based organizations or social service organizations, 12% public health agencies, and then a smattering of folks from health insurance plans. So welcome to all of you, respecting all of your different kind of backgrounds here. Let's move ahead. And wanted to share this, especially because I've already introduced some terms and terminology that some of you might be familiar with. Some of you might actually have different meanings ascribed to those terms. So we want to just level set really quickly using what we call a glossary of upstream terms here. And for today's conversation, much like a lot of the conversations that we're having these days across the country, what we try to distinguish is what you see on the first row here, which are social needs, or more precisely, health-related social needs. And define those, the way we define them is that these social needs are individual level circumstances. These are material circumstances, psychosocial circumstances, whether someone has food insecurity in their household, whether someone is experiencing housing instability, et cetera, is an individual circumstance. And there are a host of associated approaches, especially in healthcare, that we're using these days, some of which can be defined as, in the way the healthcare at least is using this term, population health management. There's those social needs, as valuable and as necessary as the work is to be able to describe how to better inform healthcare and improve healthcare by virtue of addressing individual level social needs. We also recognize that that's distinct from the second row here, which is social determinants of health. And the way that experts from the World Health Organization and others, and the CDC and others for a while have been describing this, social determinants of health technically is a term that isn't defined at the individual level. It's actually a term that more precisely speaks to underlying community-wide conditions, underlying community-wide social, economic, and physical conditions. So for example, whereas an individual might experience food insecurity, a whole community may experience a disproportionate share of food deserts, a community level issue that's driving food insecurity for certain individuals. And so the associated approaches there are what we're seeing described commonly as community health approaches, things that are bringing together multi-sector collaboratives, and certain models that you're seeing here as well as activities that many in the nonprofit hospital space will recognize, these community health needs assessments. In this row, the issue of social determinants is not so much associated with interventions for discrete individual populations, but interventions for defined geographic areas, defined zip codes, counties, et cetera. And the last thing briefly is that social needs and social determinants of health are also can be considered to be distinct from this last row, the third row here, which are structural determinants. And the structural determinants, or what are otherwise called social determinant of health inequities, are really the causes of the causes. They're not individual level phenomenon. They're not community level conditions. They're the various structural mechanisms and historical policies as the political context that shape the distribution of those conditions, that shape not just the distribution of social determinants of health, but also reinforce hierarchies and disparities in society. These are issues of structural racism. These are issues of sexism, of distribution of bus lines in one community versus another. All the forces in terms of policy and history that have shaped how social determinants of health are allocated and represented in communities is what we would see as structural determinants. So with that quick tutorial on terms right now, we wanted to call out the focus especially on social needs and social determinants, recognizing, of course, there's a vibrant conversation that we can have even today on the third level as well of structural determinants. And so with those terms now kind of set for social needs and or social determinants, as you can see here, HRSN and SDH, let's try to get a better sense of, for the topic at hand, what statement best describes how your organization primarily measures the impact of social needs and or social determinant programs. And this is a multiple choice question, so please do feel to choose all that apply. And the poll is launched. Is your organization primarily measuring processes? So for example, the number of people referred to food resources, the number of screenings that are conducted for housing and security. Are you measuring outputs like changes in the utilization of hospital use or emergency department use? Are you measuring financial benefits to your organization or potentially your partners as well, measured through cost savings or revenue generated? Are you measuring primarily social or health outcomes, such as improvements in self-reported health or decreases in depression, or improvements in food insecurity for households, or improvements in housing or chronic homelessness for a whole community? And lastly, are you measuring economic value of those social or health outcomes? What is the cost savings for an entire community from housing people, for instance, in permanent supportive housing? Again, choose all that apply. And let's go ahead and close the poll and see where our folks are at. So this is really interesting, at least for me, and perhaps for Lisa and Lauren as they share their comments today, and perhaps for each of you. The majority of folks are, and perhaps not surprisingly, measuring processes. Slightly more than half of folks are also measuring outputs like changes in healthcare utilization, which is pretty substantial. 68% are measuring social or health outcomes, perhaps measuring food insecurity or housing instability or health issues like depression or self-reported health or whatnot. It looks like 30% are measuring financial benefits, and it's interesting to note that that's not a higher number, and we'll come back to that perhaps later today in our conversation. And 27%, which is more than I anticipated, to be quite honest, are measuring the economic value of social outcomes. You're measuring the impact of decreasing food insecurity or the economic value of perhaps housing people. So we can come back to that a little bit later today. So with that level setting, thank you so much for participating in the polls. Let's move ahead now, especially knowing that we have about 130 folks on the line right now, to framing the challenge for today. And we'll hear from Lisa Richter start to share her insights on these challenges. In our experience at HealthBegins and working with partners across the country right now, we're seeing obviously the rise of partnerships and collaboratives, especially when it comes to the role of healthcare organizations, many of whom are launching programs to address upstream issues. And by that, we mean both at the individual level, trying to address an upstream need for a patient in terms of a unmet social need, or at a community level, social determinants of health. And so some of the questions we wanted to pose are, what are the pros and cons of managing interventions as individual programs, as is often the frame that we use, rather than actually approaching these as quote unquote investments within a broader portfolio. What are the challenges or barriers that prevent us from using an investment approach? And we'll go into a little bit more about what that means from our presenters today, especially as they share their lessons from impact investing or trusted broker models, and hopefully learn a bit more about what this means. But these are high level questions that I wanted to pose in terms of the challenge. Let me kind of bring it home through an example of at least one stakeholder group. And this is only one example. I think it's interesting to consider how each of you, even if you're not working in a hospital system, might resonate with this. So let's take nonprofit hospitals, for example. Over half of hospitals in the US are nonprofit hospitals. And what we're seeing more and more these days is that leaders in these nonprofit hospitals, especially those who are with community benefit departments, are starting to play a more proactive role as catalysts or connectors of health transformation efforts in their institutions, if not the communities. Financially, what this means is that in 2011, about 7% of the more than $62 billion that were spent on community benefit activities reportable to the IRS to maintain their tax-exempt status. Based on these reports, 7% went to community health improvement efforts and contributions to community groups. And it appears that this amount is increasing for a variety of reasons, including the increased focus on social needs and the moves towards value-based payments, and the mounting pressure that does exist, external pressure certainly, from policymakers to calling for more ability for these hospitals to demonstrate the true impact of their community benefit dollars. And this is leading to interesting kind of opportunities as well as some challenges here. And I'm not going to read through each of the challenges here in the slides, but I'll kind of summarize them in this next slide by putting it slightly differently. In this context, for nonprofit hospital community benefit leaders who are now moving into more of this catalyst kind of role, thinking about how not just to check the box for certain reports and to move into more proactive stances, how do they move from reporting compliance to managing a portfolio of investments, especially proactive investments, things that are actually investing money into community health and building community capacity, especially when it relates to social needs or social determinants. This can be hard, as we're seeing for some community benefit leaders who have a hard time generating and sharing investment insights because the tools that currently exist right now are made for reporting compliance, not necessarily for investment management. We know that there's competing pressures on their time. They have limited capacity because they're spending a lot of their time managing program data with not a lot of time left over to actually sit and look at social determinant goals for a whole community and mapping long-term investment outcomes. How much do we want to decrease homelessness in the next 5 years, and how are we going to align our investments to be able to achieve that? There's not a lot of time to do that because of lack of capacity. And that means there's also missed opportunities. potentially to align the different investments, both through community benefits as well as others in the community and the institution to that goal. So this is a little bit of what I'm introducing today to kind of set the table for a set of framing questions that we'll hear Lisa and Lauren now talk about. Framing questions like, how do we define quote unquote investments when it comes to social needs and social determinants in terms of social, health, or even financial returns? What keeps institutions from making investments in the first place? Who is making investments if they are at all, and how are they doing it? And finally, how could we be better at coordinating and managing these investments strategically, especially for not just populations, but for whole communities? So enough from me. Hopefully I've set the table a little bit for what will be an interesting conversation today. And with that, it is my real honor to kind of turn the baton over to Lisa. Lisa, I'll advance the slides for you. And thank you again for joining Lisa as managing partner and co-founder at Avivar Capital.
Thanks so much, Rishi, and just such a delight to be with the entire group here. I think we can probably race through some of my initial slides so that we have time to talk about investment. And you can see here that I've focused the discussion on health and health equity as a goal that I suspect many of us would share for investing. So we can move on to the next slide. A little bit about our organization. We're an SEC registered investment advisor, which essentially means that our day job is helping clients who want to use their investment capital, in our case specifically, to drive social change. So we focus entirely on the field that nowadays is called impact investing. And we do that particularly in communities that tend to have a lack of access to capital. And in large part for that reason, it's very important to us that our team is representative of the communities we serve. Next slide, please. That, by the way, is not something that's necessarily a characteristic of the community of the capital markets in general, and we're trying to change that among other things. But as a problem statement for today, I think we're all aware that U.S. healthcare expense is now almost $4 trillion, almost 20% of GDP, and growing faster than so many of the other economic indicators that influence our lives. And, that might not be so bad if we had great health outcomes and equitable health outcomes, but we know that we're not getting that value. We're not getting it as an entire population, and certainly within vulnerable populations, we have stark and persistent disparity. And many of us would like to do all we could to change that situation. And oftentimes the resources that we have, particularly as nonprofit organizations, is looking to grant programs and subsidy dollars that can help us to deliver better care, now increasingly perhaps to coordinate care, et cetera. But, the thing that we rapidly discover, and that was recognized in my field of impact investing way back in the late 60s when the field was really invented in this country, is that grant dollars are simply not enough for the scale of change that many of us are looking for. So, for example, health disparity is quantified at $95 billion per year, and that's 25% of the total philanthropic spend in this country. So we just don't have the resources through those sources. And I will say that that is the traditional starting point for my dialogues about why impact investing is important as an additional source of resources. But in teeing up today's conversation, Rishi also talked about the lack of focus that is automatically fostered if the way that we have to seek resources is basically hunting and gathering for grants. And they're all fragmented by different programs, possibly by different geographies and other jurisdictions. And this becomes an enormously time-consuming process, and one that makes it very hard to ever accumulate a scale of resources to really think about long-term objectives. Today's theme is about investing for the future. So with the next slide, what I would like to share briefly is some thoughts about investment as practiced in the profession. So from a values agnostic standpoint, not having anything to do with mission, what is the great advantage of using investment capital as a tool? Well, it's always been used, I think, by the investee, either the household or the organization that gets financing, to be able to do something today that they otherwise might have to wait years to do, whether it's buy a home or expand an FQHC. And from the investor standpoint, it's the ability to enter into a contractual relationship with the investee that's focused on the returns that the investor is going to get. Traditionally, financial returns, but in our field of impact investing, and I'm going to the second bullet, there is an emerging class, a very broad and diverse class of investors that clearly seek social and or environmental benefits alongside a financial return. And that's what is the definition of impact investing. And so here you have, in the case of those who care about health and health equity, investors who bring the same values or mission or programmatic goals to an investment situation as the investee, the recipient of capital, and that is oftentimes willing to be more flexible in structuring that capital in order to maximize the odds of realizing the mission objectives, and that frankly works together with policy and community engagement and grant making and other more traditional philanthropic activities to bring about holistic change. And we can go to the next slide. So just a little bit of background. The field of impact investing was really developed to go where markets would not go. I'll talk more about that in a moment. That's conventional capital markets, and where sometimes governments can't go, whether it's due to election cycles that make it hard to have a long-term plan or other reasons. Next slide. Philanthropy can't fully go the distance because of scarce resources. But in terms of Rishi's early question about why doesn't capital flow? Well, of course, capital flows all the time, but it doesn't necessarily flow into communities where we find vulnerable populations. And so those are typically low-income communities, communities of color, often rural communities, certainly tribal communities, marginalized from the capital markets, and often because the kinds of transactions that we need to undertake don't conform to what is quote-unquote efficient. You've heard the expression markets are efficient in the capital markets. Those traditional investments seek predictable returns, standardized formats like a mortgage, and usually a large-scale transaction because that's the way that you get the most return for the least effort. But that's not the situation we find in low-income communities that have often had a deferred access to capital. So there needs to be capacity building that goes along with the investment and other factors. And I should add that impact investing is not just to reach underserved communities and populations, but often used to enable or advance innovation in sectors that may be unfamiliar to the conventional capital markets. And one example that comes to mind, it can be controversial, but is charter schools. That was simply an unknown kind of an entity in the early 90s and got its initial fueling from impact investors at the time. And I think, even though not everyone believes that charter schools are a great solution and they're not of uniform quality, they have been helpful in saying that the achievement gap could be addressed with really high quality education. So these barriers to capital come about for a whole series of reasons, and impact investing is designed to get around those barriers. And we can go to the next slide. I think I want to say clearly that impact investing doesn't mean to understate the risk of going into otherwise marginalized communities or novel sectors. But our goal is to look at the risks and then in a creative and innovative way, working with partnerships, mitigate those risks. So what is it that makes impact investing possible? Well, like a grant or subsidy program, we have first an impact thesis. There's some social or in some cases our environmental goal that we're trying to achieve. for example, the Healthy People 2020 goals that I know everyone on the call is familiar with. But in addition to that impact goal, we have to find a way that the capital that we deploy can be repaid. And that could be from a recurring revenue stream like reimbursement to an FQHC. It could be from savings. And I'm sure many on the call have heard of pay for success transactions, where by fronting the capital to an innovative social program, we may be able to get better results in issues like providing permanent housing for homeless individuals, et cetera, that save somewhere in the system, whether it's at the emergency department or elsewhere, and that can repay an investment. You can have early stage investments that are quote unquote taken out or refinanced by later stage, and you can have growth in for-profit companies that are doing something positive, like the company Revolution Foods that brought healthy food into K-12 district schools, and because that model was successful, the company grew and paid dividends to shareholders. So not public shareholders, but the early stage venture capital investors. And so there are ways that we can use capital to achieve our goals. And when we can get those together, some kind of financial return, which can be very flexible, and a social return on investment, so focusing on return, then we have a feasible impact investment. So next slide. And I'm going to continue to go quickly. This is simply to share with the group that this is a practice that began in the late 60s with the invention of what's called program-related investing by the Ford Foundation and some others. By the way, faith-based institutions, particularly Roman Catholic nuns, were very involved in this kind of social justice-driven investing way back when. And it's developed over 50 years. It's become a professionalized practice that over time has grown to more and more sectors. Really important, because now when we're thinking about holistic strategies to drive population health within communities, we've already tested models for investing in many of the relevant sectors. So next slide, please. That, as we're changing slides, I'll say the other thing about the prior slide is that this field has always evolved through an interplay between civic leadership and visionary thinking, like the Sullivan principles that were against apartheid, combined with conducive policy, combined with innovation in the capital markets. So what's relevant for our group today is that most of the health determinants that are set out in a model like the county health rankings have tested models for how you could use finance to mobilize more capital behind what's needed, whether it's affordable housing, whether it's small business development that can employ more people, or quality childcare, and of course access to and quality of care. We'll come back to that perhaps in the discussion. Next slide for now. We've gotten to a point, because there's been enough innovation in this past 50 years, when we can really be extremely strategic in thinking about how we invest capital toward prevention versus intervention at the nexus of people, place, planet, sector, and time. So to reach underserved people in underserved communities, protecting the environment while making other improvements, making sure to invest in sectors that we know are very high leverage, but some of which are very complicated, like investing early in the life course in childcare and brain health innovation and so on. And then time, sooner rather than later. And so realizing the savings that you see depicted on the right-hand side of these slides. Next slide, please. So these tools are available. They certainly are not yet as widely used as many of us hope. And of course, part of the investment mindset when you're looking to realize returns is always to think about, well, what are the what are the risks that might stand in the way of realizing the returns, and what's the mitigation? So clearly, when we start to bring investors to the table, there's a potential of mission drift. Many people think of health as a public good and one that shouldn't be subjected to any kind of financial return expectations. So that was, interesting in the poll that came up, that those are not certainly the primary return objectives of the group on the call. And that is a valid concern. the financial markets are not known for an ethos of first do no harm. And so the mitigation is to partner with the emerging groups that really are very strongly values aligned. Complexity, of course, these getting across silos and working in partnerships to move the needle on things like upstream conditions within communities is complex. The mitigation is to form collaboratives that have the parties that we need, and to have some early easy wins to keep people energized and while planning for what's going to be a very long-term strategy that most of us will need wherever we're working. Culture change, moving from what is often an extremely competent and entrepreneurial mindset of seeking the next grant and harnessing that to one of saying, what are the primary strategic objectives of my organization, and who might I be able to engage as a partner and investor in what we're trying to do so we can mobilize more capital sooner rather than later. And the mitigation to helping that culture shift take place is to lift up examples of where it's happened. So thank you, Rishi. That's some context from our side.
Lisa, thank you so much, and a lot of rich content here, and in ways that are kind of expanding not just my mind, but I think a lot of thoughts that are going on. As a reminder, please do, if you have questions, submit those through the Q&A pane, and with that, we'll have time after the next presenter to be able to come back to your questions as part of our discussion section. And so with Lisa's really great framing here, it's my privilege to kind of hand the baton over to Lauren Taylor, who, like Lisa, is in my mind, and I think in the mind of others around the country, a national thought leader in this space, and also a friend who I'm proud to count as a mentor, if not friend, in this space. So Lauren, with that, I'll hand the baton to you, and thank you.
Thanks so much, Rishi. I was actually just going to start by saying you were a friend and mentor, because we have now been at this social determinants of health thing for, I don't know, a good 6 or 7 years. And it is not getting any easier, although we are joining comrades and friends along the way. So I thank you for your leadership. And thanks, Lisa, for teeing this up for me. I'm going to try and talk today about a specific project that I'm in the process of with Len Nichols, an economist at George Mason. And the thing that brings me to this project, just by way of framing, is I have this kind of interesting dual training where I sit at a business school now, but before I came to the business school, I trained as a minister at Harvard's Divinity School. And so the project, I hope you guys will see, is about a few things. One is about how to leverage new sources of money to invest in social determinants of health and how to manage that money. And that feels to me like it's really kind of drawing on my business school training. But then you'll see it's also about how to construct a fair process. And by fair process, I mean a fair way of bringing people to the table, selecting social determinants of health projects, pricing them, and then making investments that are moving us closer to health equity. And so that's a real tension throughout what I'll talk about today. And I think throughout the project writ large is how to both take advantage of kind of capital markets and the money side of things, but also stay true to some of the values that I hold about health equity and fairness. So the paper that came out that I'll show you in just a minute was called A Public Goods Approach to Financing Social Determinants. Maybe we can go forward one slide here. And so here's what it looked like. It came out in Health Affairs last August. Len Nichols, as I mentioned, was the co-author. And I am happy to send it to anyone if people don't have access to Health Affairs. I'm not sure if I'm supposed to be saying this out loud, but just shoot me an email and I'd be, oh no, I remember now. We made this one open source. So you should be able to Google this and not be stuck behind a paywall if you want to read the whole thing, but I will give you a brief here today. Can we go forward one bit on the slides? This is Len. I just want to show you his picture for those of you who may know him. It also gives me a chance to acknowledge that we are two white academics. He's trained as an economist. I'm trained in management. And so that leaves plenty of blind spots for us that we're trying to be proactive about identifying, particularly when it comes to these questions around equity, who gets a seat at the table, who gets a vote, and whose voices may be being diminished, if not silenced in the process. And so if concerns like that occur to you, you will see we are still in the process of designing how this means of making joint investments would work. And I would really invite and encourage that kind of critique and help. Let's go forward one slide. So I would say before I come back to the specifics of the paper and the model that we're thinking about, Stuart Butler is a fabulous social determinants of health thinker at the Brookings Institute. And he, I think, really summed up the big policy problem when he said the wrong pocket problem reduces optimal investment in non-medical factors that would improve health outcomes. And when he says the wrong pocket problem, what he's referring to, many of you will be familiar, but is this idea that, when, say, government makes an investment in housing, in some sense, they recoup returns from those investments in housing. But also if they're making investments in housing, let's say among a chronically homeless population, then whoever the health insurer or the hospital that's kind of giving out free care is that kind of holds that risk is also benefiting from those investments. And so the big challenge in social determinants of health policy is trying to figure out ways where we can actually align it such that the people who make the investments in social determinants of health are the ones who would be reaping the rewards in a clearer way. And that is, I think, kind of the million-dollar question that this work with Len is trying to address in part, although we certainly don't get all the way there. Let's go forward on the slides. So here's the question that Len and I started trying to write this paper and develop a model around. We were basically saying to ourselves, historically, public goods have been defined by economists as things that are non-rivalrous and non-excludable. That jargon is not particularly important for those who are unfamiliar, but for those of you who took an Econ 101 class in college, it should ring some bells. Usually investments in social determinants kind of sit as like a boundary object. Some of them might count as public goods, some of them might not. And what Len and I were trying to do is really say, look, if we think about them as public goods, then that opens up a whole different way for us to think about financing these investments in playgrounds, in housing, in home delivered meals, in early childhood education. Because we know that things that are public goods are consistently underinvested in. We almost never reach optimal investment from a social perspective because of that wrong pocket problem, because no one wants to pay for them individually, knowing that they will not reap the full reward. But in 2009, there was a Nobel Prize winning woman named Elinor Ostrom, who was not an economist, but won the Nobel Prize. And she said, I think our historical understandings of public goods as strictly non-rivalrous and non-excludable are insufficient. And the way that we should think about them instead is non-rivalrous, and then we should think about them as, are they subtractable or not? And the non-rivalrous bit, I think, is the key, because she said we shouldn't think about whether or not both of us can consume a unit of housing at the same time, or more than one person can consume a unit of housing at the same time. Clearly, that's probably not realistic. But the question is, can more than one person benefit from someone being housed at the same time? And I think certainly in the social determinants of health space, the answer to that question is yes. So when we make investments in housing, government benefits, healthcare benefits, maybe we would think that EMTs or some kind of ambulatory service could benefit. And you could go down the list of those social determinants that Rishi was talking about before and think about and enumerate how many different actors benefit. So back to these questions on the slide. If we take social determinants of health seriously as public goods, then how might we think differently about funding them? Well, we would think about funding them in some kind of collective manner. Some public goods are funded entirely through or primarily through taxation, right? That's a way to jointly make an investment by virtue of government coercion. The government says, here's what you owe in your taxes, and then we will allocate this money to defense or to clean water or what have you. But if we don't think that government is in a place politically or bureaucratically to levy new taxes and invest them, then we need to think about other ways to make a joint investment. And so that brings us to this black question. Len and I were asking, can we create a local purchasing mechanism for social determinants of health that allows individual organizations to pay some but not all of the intervention costs? Because that's what folks have historically wrestled with, right? No individual hospital or community-based organization wants to pay the full cost of putting sidewalks or bike lanes throughout town, because they say, well, why should that be exclusively my responsibility when so many people benefit? But then you have this real challenge historically of, well, how much should I pay versus the hospital across town versus the local school? And there's not been someone to really work that out with any kind of precision or perception of fairness. And so that's what Len and I are trying to do here. Let's go forward to the next slide. So for those of you, again, who have some econ background, I'm just gonna, hold aside the econ background. This slide is meant for me to be able to walk you through practically what this process of bringing together a coalition, choosing a social determinant of health investment, assigning prices to each person, or kind of garnering prices from each person, and then actually making the investment would look like. And in the bottom right-hand corner, you'll see this language, adapted Vickrey-Clark-Groves mechanism. That's an academic reference. For those of you who come with an econ background, there is an old public benefit mechanism called the Vickrey-Clark-Groves mechanism from which this is adapted. And so if anyone wants to talk offline about VCG or other places it's been applied, I welcome it, but not necessary if you're here just to kind of think practically about your own community and how to make investments. So there's 5 kind of buckets of things that would need to happen if you think about your own community and you say, yeah, I'm interested in this kind of thing. The first is the setup, and we can click through these kinds, there's heavy animation on this slide. So first is setup. Second is selection of an intervention. The third bit is where stakeholders in a coalition would actually bid and say, this is what the investment would be worth to me. And I'll say more in a moment. Then we obviously need to implement the intervention. We need to build the housing or the bike lanes or the playground, or we need to contract for home delivered meals. And then at the end, we need to basically reconcile this process and say, okay, did people get from the investment what they thought they were going to get? And can we now do a second round of bidding, choose a new project to jointly invest in as a group? So I should just underscore at this point, this is a really local process. We're thinking about working with local coalitions that are already existing. Maybe you're part of a coalition that was built to do an Accountable Communities of Health project. Maybe you're in California and you're part of a CACHI. There's all sorts of coalitions around the country. And my sense is, having talked to a bunch of them, that while it's really nice to be in touch with one another, people are running out of steam and energy to just keep meeting unless and until they find a real project to do together, a piece of joint work. And so this is all kind of a process and an approach for existing coalitions at the local level to really make a joint investment and do some work together. So in the setup, this is really work that would basically be done probably over email. The acronyms here, TAs are technical assistants. So for lack of a better word, that's Len and I and our friends at Altarum for right now. TBs are trusted brokers. So that would be essentially what you might be familiar with as a backbone organization or some kind of central organization that can hold information, coordinate meetings, etc. So in the setup, Len and I need to just identify a bunch of communities, and we're in the process of doing this. If at the end this sounds interesting to you, reach out and we'll add you to the Rolodex. And so we're working to identify communities, stakeholders, and in each community, try and figure out who would the natural trusted broker be. You'll see what the trusted broker needs to do in just a moment. But then the coalition needs to select an intervention that they're interested in. This could be a selection based on what the evidence says has the strongest potential return on investment, or it could be something locally that just has political priority in your community. Then we get to the bidding phase, which is really where this kind of approach to financing a social determinants of health project differs from a lot of the others. The way we would do this is say, okay, imagine there's 10 stakeholders in the coalition, and imagine that they want to build a playground. The question we would ask is, okay, everyone write down on a piece of paper what it would be worth to you over the next, and we could pick the time horizon, 1 year or 3 years, to have this kind of playground in town. And people will write down their bid, essentially saying, this is what it's worth to me, and submit that bid to the trusted broker, but they do not need to show or tell anyone else in the coalition what it is worth to them. The key is, if you sum up, if the trusted broker with Len and I's help sums up all those bids, and the sum of the bids exceeds the cost of doing the project, then we have the collective will in the community to make this project happen. And we're now in a place where if there's a little bit of surplus, right? If the project costs $100, but the bids come in at 110, well, now we actually have $10 of surplus to give back to people so everyone can pay slightly less than what they bid in the first place. Let's go to implementation. So now we have the money in kind of a central pot with the trusted broker. All the stakeholders have paid in less than they bid initially. There's been this joint agreement on what the social determinant of health project is, and we need to, contract or find a vendor to actually implement the project. And the project needs to run for whatever the timeline was. Remember, it could be a year, it could be 3 years, it could be 10 years if your community is interested in a longer timeline. But at the end, there needs to be some kind of evaluation, and that's part of what we as technical assistants would likely be helping and doing, to say, okay, did each of the players get from this investment what they expected? And what they expected may have been any of the kinds of returns that Rishi was talking about. They could be financial, they could be social, they could be, really anything. And we expect different stakeholders to come with different kinds of valuations. So a health insurer or a hospital may come with an expectation of a financial return, but a local philanthropy may come and say, here's my bid, and I don't really expect a return, or I don't require a return. Let's go forward on these slides so I can get us to a discussion. Next slide. Here's a simplistic example, and I don't need to spend too much time on the numbers, but if someone wanted to think this through concretely. Imagine that you are a local coalition and you've got, for simplicity's sake, just 3 stakeholders: a health insurer, a hospital, and a community-based organization. And you have decided you want to build a playground in the middle of town, and that playground costs $180. So now we would ask all 3 of the stakeholders to bid, again, confidentially, and they each put in the following bids. Health insurer says $110, it's worth to me. Hospital says $40, and the CBO says $50. So the trusted broker takes these bids in and says, wow, $200 is the collective valuation. That exceeds the cost of the $180 that it would actually be required to invest in the playground. And we can actually go forward with this project. We're now in the process of trying to actually figure out how much of a rebate to essentially give back to each person. And that's what the remainder of the slides are. Let's click. So before we get there, if we were to think just about fairness in its simplest sense, you might say, well, we have 3 players and the intervention costs $180. $180 divided by 3. Each of the players could hypothetically just pay $60. The challenge with that is, and now if you look across, the health insurer values it at 110 and is being asked to pay 60. And so they would say, this is great because I have a net valuation of 50. I'm good to go. This is a great deal. The hospital, however, values the playground at 40 and would be asked to pay 60. And so they would say, well, I'm at $20. This doesn't sound good. I don't really want to do this if you're going to charge me 60. And same with the CBO. Let's say they valued it at 50. You charge them 60 in a hypothetical world. They say, I don't want to do this either. But let's see how we can get out of this problem if we click forward. So what we can do is we can take that 50 surplus that the health insurer would get and actually distribute that more fairly. So instead, the health insurer could actually not gain 50. They could pay $40 essentially to the other players to compensate them. And if we click all the way to the end, I can show you what this would look like. So now what we can do is the health insurer could actually pay the hospital an additional $25, and that would make them come out whole. So just look at columns A and column C now. If the health insurer bid $110, we could charge them $100. That's not fair in the sense that everyone pays the same, but it's fair based on what they're willing to pay. And so if they value it at 110 and we ask them to pay 100, they still feel like they're good because they have a surplus. The hospital values it at 40 and we could ask them to pay 35. They too have a surplus. And the CBO values it at 50. We could ask them to pay 45. They have a surplus as well. So this is what's known as incentive compatible, meaning everyone's paying less than their actual willingness to pay for the playground. And we still collect $180, which is exactly what we need for the playground to actually go forward. The magic here, this note at the bottom of VCG, which is Vickery Clark Grove, is that everyone's net price, meaning their far right column, what they would actually pay, is less than their valuation, meaning what they bid in the first place. so that ideally self-interest drives and would perpetuate continual investment in interventions like this. Next slide. I'm going to go through these very quickly, so let's animate them all at one time. But I just want to be very clear with folks that this is kind of a conceptual solution that Len and I are trying to rip from the pages of, economic texts and academic journals and apply in real life. And that means we are likely to hit plenty of hiccups and challenges. It's very elegant on paper, but in practice, we know there will be some issues. And I just wanted to be very transparent with this group about what I expect some of those will be. So one of them is what the right scale and coalition size should be. In the examples that you see worked through in textbooks, it will be very much like what I just worked you through, kind of a 3-player game. Even in the managerial world, they say 6 to 8 is an ideal group size. But we're both really worried about excluding, especially smaller CBOs and people who have maybe a 0 willingness to pay, meaning they have no capital to contribute, but they should have a voice in what kind of social determinants are invested in a community. So let's click through those quickly. The right scale of the intervention is also not immediately obvious, but I think each community can work that out for themselves. The second set of challenges around trust. So, if you've taken game theory, you'll know there's a real risk here that people will underbid initially, meaning they will not write down on the piece of paper what their true valuation is. They'll write down something lower. That's a risk to all of these kinds of bidding solutions auctions. The thing that we're hoping will protect against it is that if everyone does it in a coalition, then we will not have the collective valuation to actually make the project go forward. And, you'll be stuck with what you have now, which is underinvestment in social determinants of health, where everyone's paying a little bit of the price for that underinvestment. Let's go to the third bit, which is exit. The last one is just trying to figure out, I mentioned Eleanor Ostrom before. Her view on any of these kind of common pool governance schemes was that you had to allow any stakeholder to get up and walk out anytime, and that made people feel more confident that they weren't being exploited. But in a kind of repeated intervention like this, you want to hold people in the group because otherwise you risk free riding, which is the wrong pocket problem all over again. And so we're really wrestling with basically how tightly to bound the group and what the terms of exit can and should be. Next slide. These political critiques, let's animate them all at once. But one is, again, just being clear. I do not think that every kind of social determinants of health intervention is particularly well suited to this. The ones that I expect local coalitions will go for first are the ones with the clearest and most sturdy return on investment. And my bet is it'll be financial return on investment, which makes me anxious because I worry about just further entrenching an attitude of expectation around financial ROI when that's not really what I want to do. The other concern I have is really around what the appropriate role of government should be. And I often think about the trusted broker and just say, man, if we're really trying to invest a lot of energy into identifying and then bolstering this trusted broker outside of government, are we just recreating the function of government outside of formal government? And what does that mean? Are we running into the problem of, charter schools are great. We don't need public schools. We can just do it outside of the government system. But we know charter schools have also had some really dicey equity implications. So those are my big concerns that I don't know that anyone will be able to answer, but I like to put them on the table as, just making you all aware that I think this is imperfect, but I really invite your help in working through it. And if you are a community that feels ready to take on something like this, please let us know. Len and I have been funded by Commonwealth to do a series of webinars to teach this concept in more depth in July and then again in September. And then we're planning to do some site visits to assess kind of the fit between this kind of model of investment and community coalitions in the fall and winter. I'm going to turn it back to you, Rishi.
Lauren, thank you. And thanks to all of you actually for staying with us through this. And I think as you'll agree, both Lisa's presentation and Lauren, what you presented as well, provoking a lot of great thoughts here for me. So let me see if we can pivot to just a really truncated version of a Wireside chat. I'll pose this question to everybody else and say, please, if you haven't already, submit your questions, continue to kind of follow along with us. And I'm going back to those framing questions as I take I'll take the first pass at asking my question of Lisa, Lauren, each of you, and then I'll also then quickly turn it over to some remaining questions that we've already gotten in. So Lisa, let me go back to something that you set up at the tail end of your presentation when you were talking about the question, the challenges that are there, so some of the risks and ways to mitigate, including this issue of kind of culture change as well as complexity. And certainly Lauren, as you're presenting as well, part of what's so appealing and interesting about the trusted broker model is that it seems to try to take on this big question of complexity and arrange it in a way that might seem feasible, make it more feasible for at least stakeholders to come together. And I'm wondering, Lisa, going back to your frame right now, as you're looking at the trusted broker model from an impact investing side, how does this resonate with you? And then as you go, I want to hear, Lauren, from you in terms of how the impact investing kind of model might fit within the trusted broker concept. So just a brief comment, Lisa,
thanks,
from you.
And I do want to keep it super brief. There have always been intermediaries that have been critically important in impact investing, and they can be partners. They can act as those trusted brokers. I think that would be the easiest thing for me to say. There are mission-driven funds that become very knowledgeable about particular issues and can facilitate co-investment to do the kinds of structures that Lauren talked about, but in an investment context. And I'm not in a formal investment context. So not saying that these are either or. I think all these models should be explored.
Great. And Lauren, to you as well, what as you're thinking about the impact investing kind of framing, how does that fit within your model or the concept that you and Len are working on?
Yeah, I think we are, we're right up against the pay for success impact investing world, and people are continually kind of saying, oh, this sounds like pay for success, or it sounds like impact investing. I think one of the differences that I see as notable is that if the community, meaning stakeholders in an existing coalition, have the capital on hand to do these projects, I think a trusted broker model can be a somewhat streamlined way of making these investments, where you don't have to go to institutional investors like a Goldman Sachs, or you don't have to go to the street to put out a social impact bond, and you may not have to go through an intermediary that is from outside your local community. And so I think that can be a benefit. But there's going to be plenty of projects. This is what I meant by this isn't going to take us to the promised land. There may be plenty of projects where the community, meaning the stakeholders in a coalition, do not have the financial reserves. They don't have the cash on hand to make the investment. And that's when I think going to one of these larger kind of intermediaries, or going for a social impact bond or a larger pay for success project, makes a ton of sense. The core intuition is very similar. I think there are really differences in essentially how local the mechanism is governed.
Let me ask one question that came in from Rebecca Copeland, and to that exact point, if the goal is to keep the investment local, as Rebecca is saying, how do you address low-income communities with limited or no local capital options? And I invite each of you actually just really quickly to comment on that. Lauren, from you, and then Lisa from you, from each of your frames of reference.
Yeah, I mean, I think that's going to be a challenge. My sense is that in most communities there is some cash on hand, and our idea is trying to say, if we pool what limited cash on hand many different players have, because they're all going to benefit from this playground, we actually may have more capital than we thought at the start. We'll certainly have more capital than any one person would have if they were just trying to build the playground on their own. But, to Rebecca's point, and I think it's a good one, we may have communities that just don't have the capital within themselves, even when they're pooling it. And in that case, I think going to something more like an impact investing, a formal impact investing model, is the way to go.
And Lisa, go ahead.
Yeah, I'll just leap in quickly to say, number one, I do think there typically is more capital in any community than is necessarily mobilized. On the other hand, I feel even more strongly that there are communities all over the United States that are heavily constrained in their access to capital, rural communities, communities of color, and so on. And I would love to just make the point that it's absolutely crucial that the regional and national investors that have capital be willing to think about making sure that some of their dollars flow into these smaller communities and underinvested communities. Oftentimes, we see that that capital flows into urban settings where there's a high concentration of people. Critically important, but it leaves lots of areas still underserved. So, you know, I think making effective markets to get capital where it needs to go is critically important.
One last question I'm going to squeeze in here, and I'll mention a quick comment as we wrap up here. Rebecca Morley asked a question, several questions actually. One about the trusted broker model. Could this process work for homogenous stakeholders, say all health insurers, or does it work best when it's a diverse coalition? Lauren, to you.
I think that's a good question, and I would say I don't totally know the answer. You know, part of this is going to be learning as Len and I go out to communities and coalitions and try and actually run this. My instinct is it works better with a diverse set who have different expectations of returns and different kinds of valuations. That will give you, I think, the most buffer, frankly, in making sure that the collective valuation exceeds the cost of doing the intervention. But that does not mean it could not work with all health insurers. I just kind of have more risk, I think, even politically, about health insurers underbidding. And so I wonder if we would just need to do multiple rounds of bidding and a lot of work to try and make sure that they were bidding true value and not trying to kind of game one another, especially imagining that a bunch of insurers in the same coalition would bring competitive instincts to the process.
Super helpful, Lauren. Well, we are at time, and I'll just mention one thing here, which is that these are questions that we're not only asking for Lisa and Lauren, but questions, as Lauren was kind of indicating, that we're all kind of grappling with right now, including the ones that are on the screen. The questions that you have submitted, we want to thank you for. We've actually triaged them and sent them over via to each of our presenters. And what we'll do is to commit to collating some of the high-level responses, if Lisa and Lauren are willing, to kind of take a quick look at some of the questions that you've already shared electronically. And when we send the recording out, perhaps send some high-level responses back from Lisa and Lauren to some of your additional questions we weren't able to get to. So I want to say thank you to everybody for joining us today. As we mentioned earlier, we're going to send the recording out to all registrants. And finally, as soon as we sign off today, you'll get a quick survey that will pop up on your screen. We would really appreciate it if you could take a minute to fill out the couple of questions that we're going to send to you. I want to say thank you to Lisa and to Lauren, and thank you to everybody on the line today. Hope to see you all again on the next webinar. Let's continue the conversation on Twitter or LinkedIn or whatever your preferred social media platform is, and we'll talk to you online. Thanks, everybody.